Hello friends, this is Professor Dr. Sameen Afzal Junejo from Hyderabad, Sindh, Pakistan, Afzal Eye Clinic. Friends, I will show you a video today. This case was operated by me at my clinic, and the patient had a semi-dilated pupil with rock hard brown hypermature cataract, and this case was operated on high vacuum of 550, and the Phaco power was set at 80%, and the flow rate was 40%, 40 cc per minute. The anti-clockwise anti-recapsulorhexis was performed. The rhexis was about 5 to 5.5 millimeters in diameter, and the approach is usually through the surgical limbus, and the surgical limbal approach is my ideal surgical site. A round curvilinear rhexis is performed, and now full thickness corneal incision is being given through the surgical limbus beyond the gray line with the help of a 2.75 millimeters diamond keratome. Full thickness incision should be given beyond the gray line at the end of the surgical limbus, because a slight bleeding can help the wound to heal rapidly without resulting in any leakage postoperatively. A side port is formed with the help of 1.4 millimeter straight diamond knife, and the viscoelastic dispersive and adhesive both are injected into the anterior chamber. As you see that the pupil is a bit constricted, maybe due to the release of prostaglandins E2 from the iris stroma, and also due to the manipulation. After doing the hydrodissection only, because delineation is not possible in such a hard cataract, Phaco emulsification is started, and the groove is created exactly in the middle of the nucleus, and under a high vacuum the lens nucleus is pulled apart and splitted into small pieces through the equator by means of a Phaco chopper through the side port. The hard nucleus is further fragmented into small pieces through my favorite chick feed technique. Again, the nucleus is grasped at equator, pulled apart, and divided into two small pieces by means of a chopper, and Phaco energy is being emitted by keeping the direction of the phaco tip with the bevel at the lateral side, neither up nor down but on the lateral side, so that the phaco energy should not strike the corneal endothelium or the posterior capsule, resulting into the posterior capsular tear. In such cases, and usually during the phacoemulsification process, the phaco tip bevel should always be at the lateral side. After removing the hard nucleus, the epinucleus is also being aspirated under high vacuum of 550, and now the phaco tip is removed from the incision and there is no more nucleus and epinucleus inside. In the presence of OVD dispersive and a small amount of adhesive as well, irrigation and aspiration is being done with the help of two-way Simcoe cannula. To remove the hard cataract under the high vacuum with the help of a phaco machine is not difficult. One should have the patience and the controlled release of phaco energy should be done during the process, keeping the phaco tip with the bevel on the lateral side. And now the viscoelastic is again injected prior to do the intraocular lens implantation. In this case, I will be doing with the IQ foldable one-piece intraocular lens. It is a pre-folded lens, and this lens has got a very good memory and quick placement and fixation in the bag. In this patient, I will frequently instill the topical steroid drops because the pupil is myosed due to the release of prostaglandins E2, so there are more chances of postoperative inflammation. That's why I will use the steroids topically. Lens is being implanted exactly into the bag, and due to the sharp memory of the haptics, the lens has got its place into the bag without dialing. And now I will excise the pterygium with number 11 surgical blade. Up to the limbus. I will not remove the margin of the conjunctiva because the marginal conjunctiva is tremendously embedded with the stem cells, and the stem cells are necessary for the quick healing and prevention of the corneal neovascularization. The viscoelastic solution is being removed by irrigation with the Ringer's solution with the help of Simcoe cannula. The visco irrigation is definitely being performed at the end of the procedure in order to avoid the postoperative transient rise of intraocular pressure and the postoperative cellular reaction. Just to avoid postoperative cellular reaction, the viscoelastic material is being irrigated as much as possible at the end of the procedure. Anterior chamber is very well formed in this case. Further dissection of the thick subconjunctival fibrous connective tissue from the corneal surface is being performed. There is a complete closure of the corneal incisions at the side port and also at the full thickness corneal incision site, and there is no any single drop of blood resulting into the surgical hyphema. Dear friends, if you like this video, please subscribe my channel, like the video and push the bell icon so that you will be able to receive more interesting videos in this topic. Thank you very much.